Next, we have paper number 13, Association of Pre- and Perioperative Vein Mapping with Hemodialysis Access, Characteristics and Outcomes, presented by Hannah Wolf with the senior author Gail Tang from University of Washington.
Thank you. Good morning, and thank you to the VESS for the opportunity to present our work. Thank you. We have no financial disclosures. Views expressed here do not reflect the official position of the VA or U.S. government. In regards to planning for hemodialysis access creation, current QDOKI guidelines recommend utilizing preoperative vein mapping studies for high-risk patients only and clinical evaluations for all normal-risk patients. QDOKI considers high-risk patients to be those with various comorbidities, such as those with peripheral vascular disease, coronary artery disease, those with vessel damage from PICC or central venous catheter insertion, prior surgery or trauma to the neck or upper extremity region, and certain physical limitations, including morbid obesity. The updated guidelines are based on a small randomized trial aimed at assessing the impact of selective versus routine duplex ultrasound prior to surgery. While no significant differences were observed in primary failure rates or total complications at 90-day follow-up, there was a trend that suggested that preoperative mapping may be of benefit. Many choose to continue evaluating all patients with preoperative mapping. Our institute has not updated our practice from former QDOKI guidelines and still obtains preoperative vessel mapping for all patients. Furthermore, we also obtain perioperative vessel mapping after induction of anesthesia on all patients to better assess venous anatomy and suitability of the planned access site. The perioperative ultrasound is performed by the operating surgeon. It takes less than 5 minutes and focuses on confirming results of the preoperative vessel mapping and checking for more favorable sites. Intraoperatively, we assess for veins adequate for attempt of autogenous access using 3 millimeters as our cutoff. And we noticed that our perioperative ultrasound findings frequently did not match the preoperative assessment, which prompted our further investigation and the start of this project. So we thought about what may have been causing the differences observed in perioperative mapping and came up with a few explanations. First, patients arriving to their preoperative mapping study may be in a condition where their veins are not maximally dilated. So be it from a cold room, dehydrated or anxious state, these factors could all make it appear as though the patient is not an appropriate candidate for a certain level of fistula creation based on their preoperative mapping alone. Additionally, perioperative ultrasound was always performed after induction of anesthesia, which likely led to dilation of veins previously judged to be unsuitable based on preoperative mapping. And this last notion is supported by many prior studies which have indicated that veins dilate with regional or general anesthesia, and that vein compliance is a large predictor of fistula maturation. It's also of note that our practice utilized primarily regional with only occasional general anesthesia in all of our patients. So our study aim was to investigate the utility of both pre- and perioperative vein mapping. We hypothesized that by using both sets of imaging studies, particularly that in changing the planned access site based on perioperative ultrasound, that this would result in more anatomically preferable access site creation for our patients. We performed a retrospective chart review of 130 patients with initial hemodialysis access from January of 2017 to December of 2021 at the Seattle Puget Sound VA. All 130 of these patients underwent pre- and perioperative vein mapping evaluation. All fistulas were created in concordance with QDOKI guidelines, which promote the distal to proximal approach in the patient's non-dominant arm. We grouped patients into 2 categories, the first being a group whose final fistula access site was congruent with what was found in their preoperative vein mapping study. The second group was considered to be non-congruent, as their final fistula was something different than what was considered to be the best option based on their preoperative ultrasound. Our primary outcome was fistula maturation, defined as the day the patient was successfully dialyzed through their surgical access site, or when their operating surgeon cleared them for dialysis based on clinical assessment or documentation of mid-brachial flow volume of at least 600 cc per minute. We also recorded functional patency and number of procedures needed to achieve maturation and maintain patency. Results were analyzed using Pearson chi-squared, Moods median, Student's t-test, and Kaplan-Meier curves. No significant differences were observed between groups in regards to demographics, including age, sex, and various comorbidities. We'd also like to point out that many of our patients were either obese or morbidly obese, which would have made relying on the physical exam alone very challenging. And additionally, around a quarter of our patients were already on hemodialysis at time of access creation. Routine preoperative mapping also identified various arterial issues, including high bifurcation, diseased radial artery, incomplete or radial-dependent palmar arch, and inflow stenosis. Arterial issues were identified in 42% of our patients, and these findings were accounted for and factored into each patient's operative plans in the hopes of optimizing their chances of reaching maturation. We found that in our patient population, utilization of both pre- and perioperative mapping resulted in no change in site placement for 49% of our patients. In other words, these are the patients whose operative plan stayed consistent with their preoperative assessment and did not change based on their perioperative mapping results. The remaining 51% of patients did undergo a change in their operative plan based on the findings from their perioperative mapping after induction of anesthesia. 35% of our patients were changed to a more favorable access site. 23% of our patients benefited from a change to a radiocephalic fistula, 9% to a brachiocephalic fistula from either previously planned graft or brachiobacillic fistula, and 3% to a brachiobacillic fistula from a previously planned graft. In 16% of our patients, their perioperative ultrasound did result in a less anatomically advantageous fistula or graft, which indicated to us that use of perioperative ultrasound allowed for identification of new or previously unrecognized issues, again, hopefully optimizing the patient's likelihood of successful access creation. Roughly a quarter of our patients in this anatomically inferior category included those whose site changed from their non-dominant to their dominant arm while maintaining the same level of access. For example, 9% of these patients received a radiocephalic on their dominant as opposed to their non-dominant arm as previously planned. The remainder of these patients required either a same level switch to their dominant arm or a higher level fistula or graft, and you can see the rest of the distribution here. We found no significant difference in the median maturation rates or procedures needed to achieve or maintain maturation between the congruent and the non-congruent groups. As you can see, 86% of fistulas matured within the congruent group and 82% within the non-congruent group. Looking at our Kaplan-Meier curve, we have on the y-axis patent fistulas remaining. On the x-axis is time for maturation in a matter of months. And congruent is represented here in blue and non-congruent group is in red. The shaded region represents the 95% confidence interval. We found no significant difference in the time for maturation to the date of failure between both groups. So in conclusion, adding perioperative vessel mapping in addition to preoperative mapping resulted in more optimal access creation with maintained rates of maturation and functional patency. Despite current QDOKI guidelines, our findings suggest that utilization of perioperative vessel mapping after induction of anesthesia, in addition to routine preoperative mapping, may be of benefit. So thank you very much, and I welcome any questions.
Thanks very much. Great talk. Who's doing your preoperative mapping? I notice a tremendous difference when it's done in my vascular lab versus when it's done in a general ultrasound office at the hospital, by somebody who's doing gallbladders and soft tissue stuff the rest of the time.
So we had two different vascular labs that our patients were seen at. So they both had their own set of guidelines that they followed.
But all dedicated vascular sonographers?
All vascular. Mm-hmm.
Another question. So is there a standard protocol for the surgeon that is doing this ultrasound? Because, and the reason I ask is, ultrasound we all know is very operator dependent, and which machine are using the same machines, using the same protocol. Could you describe a little bit of that? Because I think yours adds to the large body of literature now that says that we all should probably be doing this, but I think maybe it's time for us to refine our techniques to get as outstanding results as you did.
Right, thank you. So we did not have a formal protocol in place, so the operating surgeon would do the ultrasound. It takes about 5 minutes. They used a cutoff of around 3 millimeters. But other than that, there was no formal protocol, which we would love to consider implementing in the future, and we would suspect that in doing so, that might actually increase the beneficial results even more, just because we would like to have more of a protocol so that you're actually looking at the full length of the arm and making sure that you're getting the best possible site.
Yeah, this wasn't any fancy ultrasound. This is the sonosite that we use, that everybody uses in the OR, not like a dedicated machine or anything like that, just a straight up sonosite.
Thank you very much.
Great, thanks very much.
Thank you.